Today, we're actually doing something a bit unique. We're diving into what we're calling a case file from the New England Journal of Medicine. We're kind of reframing a really rigorous medical study as more of a narrative investigation. Think of us as your guides.
That's exactly right. Forget just the dry summary. Our mission today is to transform this, highly scientific report into something more immersive. We want you to understand the detective work behind medical research, not just what they found, but the why, the how, and what it all means.
Right. So our case today focuses on a pretty significant phase 2 clinical trial. It's investigating a combination therapy for a really challenging type of kidney cancer using two drugs, Bevacizumab and Erlotinib. It's complex stuff, so let's start unpacking it. #TAG1, the patient in the room, the why.
Okay, so every medical investigation, every study like this, it always starts with a problem affecting real people.
And for this deep dive, we're looking at patients facing a very serious diagnosis, advanced renal cell carcinoma. Specifically, a rare inherited form called HLRCC, that's hereditary leiomyomatosis and renal cell cancer, and also a related type, sporadic papillary renal cell carcinoma.
And what's really compelling, I think, is that HLRCC is inherited. It's a syndrome. So it's not just kidney tumors. It often shows up with benign tumors, too, like in the uterus, leiomyomas, or even on the skin.
Wow.
Imagine dealing with an inherited condition that pops up in such different severe ways. And, many patients in the study, they'd already been through the ringer. They tried standard treatments, maybe cytokines, chemo, and their disease was refractory.
Meaning he just wasn't responding anymore.
Exactly. It wasn't responding, which just highlights how urgently new options were needed for these folks.
That inherited part, HLRCC, sounds incredibly difficult. Does its unique biology offer any clues for treatment, like vulnerabilities?
Absolutely. That's the key, really. If we look at the underlying biology in HLRCC, it's critical for understanding this whole investigation. It involves a very specific genetic flaw, basically a loss of activity in an enzyme. It's called fumarate hydratase, or FH.
Okay, FH enzyme.
And when that enzyme isn't working right, you get this overaccumulation of a substance called fumarate, which in turn messes up a key cellular process. It leads to something scientists call a pseudohypoxic state.
Pseudohypoxic. So, fake lack of oxygen. What does that actually mean for the cell?
Pretty much. Essentially, the cells act as if they're starved for oxygen, even when there's plenty around. It's like a false alarm that tricks them into overproducing certain proteins. Think of them as master switches, HIF1 and HIF2.
Okay, master switches.
And these switches then crank up the production of factors that encourage new blood vessel growth. VEGF is the big one.
Right, VEGF. That's like the tumor supply lines, yeah.
It's exactly feeding the tumor. And they also produce other growth factors like TGF-alpha. This is why HLRCC tumors are often packed with blood vessels, highly vascular. And it's why targeting these pathways, VEGF and others, seem like such a logical approach. There was even preclinical data, lab stuff, using cell lines like UOK262 from HLRCC patients. And it showed these tumor cells were, and this is a quote, exquisitely sensitive to ambient glucose concentration.
Meaning they really rely on sugar for energy.
Yeah, hints at a specific energy dependence, like finding a unique vulnerability, a chink in the armor you can target, #2, the trail of discovery, the how. So getting to this specific trial, it wasn't just a sudden idea. It really built on years, decades even, of careful work understanding these pathways.
Right, the basic science groundwork.
Exactly. And the pivotal aha moment, you could say, was realizing that if they targeted VEGF with one drug that's Bevacizumab Blixi, and also targeted another growth pathway, EGFR, with a different drug, Erlotinib, they could maybe hit two critical downstream effects of that HIF activation we talked about.
Ah, so a simultaneous two-pronged attack. Makes sense.
Precisely. Strategic.
So they zeroed in on these targets. Why these two specific drugs, Bevacizumab and Erlotin? Were there other options on the table?
That's a good question. Well, bevacizumab, which people might know as Avastin, it's basically a specialized antibody. Its job is to block VEGF. So, like we said, cutting off the tumor's blood supply, stopping those nutrient deliveries.
Got it. And Erlotinib?
Erlotinib, or Tarceva, is different. It's a small molecule drug, a highly selective inhibitor for a protein called EGFR. So it blocks a different but also crucial growth pathway that tumors often hijack. And importantly, both these drugs already had some track record. They'd shown activity against other cancers like colorectal or lung cancer.
Okay, so they weren't totally new.
No, not brand new. And their side effects were reasonably well known, which is also important. The thinking was maybe combining them could be more powerful than either one alone, a synergy effect.
So with that strategy, how did they actually set up the experiment? What did this investigation look like in practice?
Okay, so this was what's called an open-label, single-arm phase 2 study.
Open label means everyone knew what they were getting.
Yes, doctors and patients knew the treatment. And single-arm means there wasn't a control group getting a placebo or a different standard treatment. Everyone got the combo. The investigation focused on two separate groups, patients with HLRCC and patients with that sporadic papillary type. And the main goal of a phase 2 like this is really to see if there's enough promise, enough of a signal of activity to justify bigger, more expensive studies later on.
Like a feasibility study almost.
Sort of, yeah. Specifically, they set a bar. They needed to see at least 3 patients out of 20 have a positive response. If they hit that, they'd consider it worthy of future investigation.
Okay. Now, I saw something in the appendix about the trial registration dates. It mentioned the NIH being less conversant with certain requirements back in 2010. What's the story there?
Yeah, that's an interesting point about how things change in research oversight. It touches on trial transparency. Back then, around 2010, the NIH was registering studies within 21 days of starting, following the FDA rules at the time. But international standards, like from the ICJME, have evolved. They now strongly emphasize registering trials before the first patient is even enrolled.
So the standards got stricter over time.
Exactly. It's a good example of how the research community adapts to improve transparency and ethical conduct. But it is important to note, for the HLRCC patients in this study, their enrollment did happen after the trial was fully registered according to the standards of that period. #tag 3. Cracking the code. That way.
Right, so the background's set, the investigation is designed. Let's open the actual case file on the study itself. What exactly happened? How did they gather the evidence?
Okay, so patients got a fixed starting dose. Bevacizumab was given through an IV every 2 weeks, and Erlotinib was a pill taken every day. The treatment cycles were 28 days long.
And who could participate? Were there strict rules?
Oh, yes. Very strict eligibility criteria. You needed measurable disease, something they could actually track on scans. Patients had to have a good performance status, basically, be well enough to tolerate the treatment, ECOG score 0 to 2, no cancer spread to the brain, adequate organ function, like liver and kidneys working okay, and importantly, they couldn't have had too many prior treatments targeting that VEGF pathway, and specifically, no prior bevacizumab.
Okay. Standardizing the patient group as much as possible.
Exactly.
So how did they measure if it was working? What counted as success in this kind of initial investigation?
The main thing, the primary endpoint, was the confirmed overall response rate.
Overall response rate.
Which means, did the tumor significantly shrink? That's called a partial response. Or, best case, did they disappear completely? That's a complete response.
Got it. Shrinking or disappearing. Were there other things they measured?
Yes, secondary endpoints. They looked at progression-free survival, basically, how long patients lived without the cancer getting worse. Also, overall survival, how long patients lived in total, and how long any responses lasted, the duration of response. And patients were monitored incredibly closely. Daily blood pressure checks at home, regular physical exams, lab tests. Any side effects or adverse events were carefully recorded using a standardized system. It's called the CTCAE from the National Cancer Institute, version 4.0 at the time.
So very meticulous tracking.
Very. It ensures consistency in how side effects are reported across different studies.
Now here's where the real detective work seems to get interesting. What kind of data were they collecting beyond just, how big the tumors were?
Right. They went much deeper than just scans. They performed really extensive correlative studies, molecular detective work. This involved taking tumor biopsies, both before treatment started, at baseline, and then again during treatment.
Biopsies during treatment. Wow.
Yeah. And they analyzed these samples to confirm the FH status. Was that enzyme working or not? They looked for specific genetic mutations in the FH gene, all sorts ones that might completely stop the enzyme, others that might just change it subtly. Things like C.797DPT, Q254X, R233H, even whole gene loss.
So really detailed genetics fingerprinting.
Absolutely. And they also measured the levels of key proteins like HIF, EGFR, VEGFR2 to see if the drugs were actually hitting their intended targets within the tumor cells. They even looked at markers of blood vessel formation like VEGF levels in the blood and tried to find circulating tumor cells, cancer cells floating in the bloodstream.
That sounds incredibly comprehensive, like trying to understand exactly why it might be working or not working.
Precisely. It's about linking the clinical outcome back to the underlying biology.
Okay, but every investigation needs a cross-examination, right? What are the built-in limitations or challenges with interpreting results from this kind of study design, a phase 2 single-arm trial?
That's a really critical point.
Yeah.
You have to be careful how you interpret the results because it's phase 2, open label, single arm. Its main job is to find that signal, like we said. Is there enough activity here to justify bigger trials? It's not designed to definitively prove this combination is better than, say, a placebo or another standard treatment. You can't do that without a control group.
Right, no comparison group.
Exactly. So you can't say for sure that any effects seen are only because of the study drugs. Other factors might play a role. And the paper itself notes something interesting. Trying to analyze the impact of prior VEGF inhibitor use was really tricky. It was, quote, highly confounded with other treatments patients had received before. So complex, they couldn't really isolate its specific effect in certain analyses.
For real-world patient histories make clean analysis difficult sometimes.
Very much so. It shows the challenge of studying new drugs in people who've already had various other treatments. Phase 2 gives clues, important clues, but it's rarely the final word. #4, the ripple effect. The so what.
Okay, so let's say this combination did show that promising signal. How might that potentially change things for patients at the clinical crossroads, as you put it?
Well, yeah, if the signal was strong and positive, it could really pave the way for a much-needed new treatment option, especially for these patients with HLRCC or papillary RCC who often don't respond well to existing therapies. But, and this is a big but, it's also fundamentally about managing the side effects. These are potent drugs.
Right. They're designed to kill cancer cells, so they're not gentle.
Exactly. Take bevacizumab. High blood pressure, hypertension is really common, can affect, 20–30% of patients, maybe more. We're talking noticeable increases in systolic pressure. So strict management is absolutely key. Home monitoring, adjusting doses, sometimes even having to stop the drug if it gets severe.
And were there other serious side effects they had to watch out for? Things beyond blood pressure?
Oh, yes. Though thankfully rarer, bevacizumab carries risks seen in other trials like serious bleeding, blood clots in arteries, or even holes forming in the bowel GI perforations.
Wow, okay.
If any of those happened, the protocol was clear. Stop the drug permanently. And erlotinib has its own profile. Rash is common, often an acne-like rash, which can usually be managed with creams and specific meds, but it also carries a rare risk of serious lung problems, interstitial lung disease.
Affecting the lung tissue itself.
Yes. And another thing with bevacizumab is wound healing. It can interfere with it. So patients needed to stop the drug for a good while, like 4 to 8 weeks before and after any major surgery, to allow time for proper healing.
So that really underscores the need for intensive monitoring.
Absolutely. And that careful balancing act clinicians have to perform, weighing the potential benefit against the very real potential harms. It's a partnership, really, between the patient and the medical team.
Which leads us nicely into the next area, the ethical maze. What kind of moral dimensions does a study like this bring up?
That's always a crucial consideration in clinical research. Patient safety and informed consent are paramount, especially when you're dealing with rare diseases and powerful drugs. Patients volunteered for this. They were exposed to risks, not just from the drugs, but from the study procedures, too.
Like the biopsies you mentioned.
Exactly. Biopsies have risks: bleeding, infection, potentially injuring nearby organs, and repeated CT scans mean radiation exposure. The report even estimated it could be up to nearly 14 rem per year in some cases, which does carry a small increased long-term cancer risk.
So the potential benefits needed to be weighed against all those risks.
Absolutely. And the consent process has to be incredibly thorough, making sure patients understand the potential benefits, like tumor shrinkage, but also that it's not guaranteed to improve their symptoms or help them live longer. They need to know all the alternatives, all the known risks, and the requirements for contraception for both men and women were also strict.
Why was that?
Because of the potential unknown risks these drugs could pose to reproduction or a developing fetus. It's about protecting potential offspring, too. So it's this constant balance of seeking progress while ensuring transparency and safety.
As we sort of debrief on this whole deep dive, this investigation, what are your main takeaways, and maybe what do you see happening next for treating these kinds of rare cancers?
For me, what really stands out is just the persistent effort, the ingenuity involved in trying to find anything that works for these rare, often really aggressive cancers. It shows how powerful it can be when we target specific molecular pathways once we actually understand the underlying biology. The FH enzyme story is a great example. And the sheer meticulousness of this trial, the detailed safety checks, the really deep molecular studies, it's a testament to how clinical research pushes forward, but always tries to put patient well-being first. It's painstaking work.
It really sounds like it. Slow, careful steps.
Yeah.
Necessary steps. So here's maybe a final thought for you, our listeners, to mull over. How do we, as a society, keep encouraging this kind of groundbreaking research for rare diseases? Where the patient numbers are small, the studies are complex and expensive. How do we support that innovation while always upholding the highest standards of safety and ethics?
That's the ongoing challenge, isn't it? A really important balancing act.
Well, that's our deep dive into the case file of this really compelling clinical trial. We hope you feel a bit more informed, maybe a little more curious too.
Yeah, and perhaps have a greater appreciation for the whole intricate world of medical research.
Understanding that journey from the initial scientific idea all the way to a potential treatment in the clinic with all the hurdles, it's definitely a deep dive worth taking.
Absolutely.
Thank you so much for joining us. We'll be back next time with another stack of sources to unpack for you. Until then, keep digging, keep learning.